The TEACH curriculum and slides were developed and compiled with funding from the Government of Ontario, Ministry of Health and Long-Term Care. Content of the slides are primarily based on evidence-based guidelines from the following sources. And now I'm going to hand it over to our faculty presenter for today, Dr. Nadia Aleem.
Okay, perfect. All right, good afternoon, everybody, and welcome to this TEACH webinar. So I'm covering a topic that includes talking about mental health and tobacco use. It is a very, very big topic and expansive. We could expand in many directions speaking about this. So I'm going to be speaking in general terms today about how to approach tobacco use in a population of people who struggle with psychiatric illness. There will be time for some questions at the end, and of course you can always type your questions and I can respond to them by email at a later date. So we're going to go over the learning objectives. The first is just to do a brief overview of the prevalence and associations between tobacco use and psychiatric disorders. The second, we're going to look at some tools and strategies, some approaches basically to be able to address tobacco use in those with mental illness, and just look at some treatments towards the end for tobacco use. Again, we're going to be focusing more on an approach to assessment and to be able to come up with a treatment plan for clients who struggle with mental illness. All right. So why is this population specifically important? Well, we do see smoking rates going down globally. However, in one specific population, and that's a population of people with psychiatric illness, the smoking rates are pretty much staying level. And it continues to be a huge risk factor for mortality. So if you suffer from a psychiatric illness, chances are that you are 2 to 4 times more likely to smoke or have smoked within your lifetime. And then you are more likely, of course, to suffer all of the medical risks associated with smoking. Not only that, and this area is very much in its infancy or childhood, I guess, more and more we're beginning to see that people who struggle with nicotine dependence suffer from permanent damage to their brains, to many of the structural components in their brains, and this can increase psychiatric illness and also make it harder to treat psychiatric illness. So there's been lots of research done on how smoking affects your heart, how it affects your blood pressure, but we have kind of neglected smoking's effect on the brain. And given that there's such high prevalence of smoking in people who suffer from psychiatric illness, this is a very important area to continue to investigate and consider. So I'm just getting a note that I need to speak louder. If somebody could let me know if the volume is better as we go along, that would be great. Okay, so smoking prevalence rates. This is just a brief slide to look at smoking prevalence rates amongst people with psychiatric illnesses. And this slide is helpful because it shows the breakdown of smoking, substance use disorders, not only as psychiatric population in general, but broken down amongst all the major psychiatric illnesses or classifications of psychiatric illnesses. What you notice right away is that smoking prevalence is particularly high in those who struggle with schizophrenia or bipolar disorder. Major depressive disorder and anxiety disorders such as panic disorder and OCD are not that far behind. However, anxiety disorders in general tend to be lower than those who struggle with psychotic illnesses or bipolar illnesses. Substance use disorders in these populations follow similar trends to those of nicotine dependence. All right, so when we're looking at smoking cessation, we have to take a very global approach to looking at measures to facilitate smoking cessation. And this slide is one approach to looking at it. So if we think of the vector, and the vector in this slide would be the agencies responsible for nicotine dissemination. So tobacco companies and legal agencies that set guidelines for pricing on tobacco. And there are numerous strategies that have been looked at as environmental strategies to decrease smoking cessation. The reason that this slide is particularly important for those who suffer from psychiatric illness is that in the past there have been specific marketing strategies targeted at those clients who struggle with mental illness. I'm not going to go into details in this lecture as to what some of those strategies are, but if any of you are interested, there is lots of literature historically on how people with psychiatric illness have been specifically targeted by tobacco companies, which was postulated to possibly account for the increased risk of smoking in that population. The agent that we consider in this slide is, of course, the cigarette, and the cigarette in and of itself has properties within it and effects that it has that may make people with mental illness more susceptible to becoming dependent. Many of the neurotransmitters that are responsible for the development of mental illness include acetylcholine, serotonin, dopamine, norepinephrine, and all of those are affected by cigarettes as well as other addictive agents. Then we look at host factors. So what host factors are is examining any kind of susceptibility that somebody might have to becoming dependent on nicotine. And a body of research postulates that mental illness in and of itself, anxiety disorders or psychotic illness, share a common pathway with nicotine dependence such that there's an increased vulnerability on a biological level, also on a genetic level, for people with mental illness to develop nicotine dependence or higher rates of nicotine dependence. So in summary, there are environmental factors that influence this population. The cigarettes themselves might have specific impacts on symptoms of mental illness that could make them particularly favorable for patients who suffer from any kind of mental illness. And then individuals who suffer from mental illness in and of themselves might have an increased biological or genetic vulnerability to developing nicotine dependence. I've talked about this slide a little bit already, and I don't go into any details in this presentation about specific pathways that are affected for each of the illnesses. There's much literature being developed and much research being produced in this area. Most of the research is specific to each illness, so you will look at pathways specific for panic disorder or pathways specific for bipolar illness. And in summary, many of the neurotransmitters are implicated. So changes in neurotransmitters are changes in the messaging system within your brain. And many of you may or may not have heard of many of the neurotransmitters that are involved in mental illness development. They include serotonin, norepinephrine, dopamine, GABA, and glutamate. But we're looking beyond neurotransmitter changes within mental health as possible pathogenetic mechanisms in the sense that there's also some evidence around mechanisms of inflammation that may be causing mental illness. And we know that cigarettes also cause increased inflammation. So we're still not sure how cigarettes can perpetuate mental illness or maybe even make mental illness treatment resistant. However, neurotransmitters and inflammation are two major ways in which research is being directed at this point in time. All right, so let's talk about an approach to addressing both nicotine dependence as well as helping to treat psychiatric illness. This becomes complicated because there are differing opinions as to whether this should be done concurrently or sequentially. There are a body of people who believe that treating nicotine dependence aggressively in the context of acute mental illness is not preferred, and that there should be a focus first on mental illness and then on smoking cessation. And the theory behind that for some people is that smoking is used as a coping mechanism, and it may be felt to be unusually cruel to take away that coping mechanism in the face of an acute illness. Other people, and in CAMH is included in this, are looking at addressing both nicotine dependence as well as addressing psychiatric illness concurrently. So some of you may or may not know about recent changes at CAMH around smoking cessation. Currently, CAMH is a tobacco-free institution, so no tobacco is allowed in any of the premises. That includes in inpatient units. And this is quite a different step, quite a progressive step, as in the past, many acute inpatient units have allowed smoking and smoking passes. And that was very much the culture of psychiatric units up until this point in time. So making this policy change indicates that we are taking a concurrent approach to nicotine dependence in psychiatric treatment, and that both need to be addressed concurrently. All right, so what are the components of a good and thorough assessment or concurrent assessment for psychiatric illness and smoking cessation? Basically, you want to do a thorough psychiatric assessment as you would in a psychiatric population. And in addition to this, you want to do a thorough nicotine dependence assessment. However, in this population, it is important to also see how these two illnesses overlap. Right. So your general tobacco use assessment should include a documentation of someone's current use. So this could be the number of cigarettes that they're currently smoking. However, that often isn't enough, and in order to determine degree of dependence, you want to be looking a little bit more deeply into what the patterns of cigarette use are. You could use a nicotine dependence scale, which will look at craving, time of cigarettes, number of cigarettes used, or as well as look at attempts to quit in the past and situations which have allowed people to quit in the past. So if people have made several attempts to quit and have failed, this might indicate higher degrees of nicotine dependence, or it may indicate that there's a stronger correlate with the psychiatric illness and that the psychiatric illness may be preventing complete nicotine dependence, nicotine cessation. There is a list of some of the components of the history. When you're looking at how they overlap, you want to be doing almost a timeline of nicotine dependence and quit attempts. And what I do is do a concurrent timeline with the psychiatric illness. So in most cases, psychiatric illness like anxiety, depression, even psychotic illnesses remit and relapse. So if you have a timeline of the remissions and relapses of the psychiatric illness, you could almost overlay the tobacco use on top of that. And that visually for clients is very helpful because it allows them to see how the two are intertwined. Another approach is to look at what kind of cognitions, feelings, or psychiatric symptoms trigger the nicotine use. Some people might have very good insight into this. Some people might have very poor insight into this. So you can begin to investigate this in your initial assessment as well. And in that way, you're setting the stage to demonstrate to the client that you're going to be addressing both the nicotine use as well as the psychiatric illness concurrently, and it allows them from the get-go to be able to become used to the interrelationship between the two. All right, and this just, again, this slide says exactly what I've just been saying, that you want to look at substance use and mental illness concurrently, and you want to be able to overlay them with periods of remission and exacerbation. What I didn't mention is it's also important to look at other substance use, alcohol use, cannabis use, at the same time that you're looking at nicotine use, because often alcohol use and nicotine use will go hand in hand. if there are problems in both areas. All right. The last point, or the second to last point there, looks at current medications. What can also be helpful is to do a medication history. Well, you should be doing a medication history during your initial assessment. But again, the timeline on that medication history can be very important. And what you can sometimes see is that with the initiation of certain medications, for myself and my work, I deal mostly with depression and anxiety, and some of the medications, antidepressant medications that are used to treat depression and anxiety, may have some effects on smoking cessation, including Wellbutrin. It is important to see if during those times of medication initiation, smoking rates have gone down, because that will help guide your treatment as well. All right. If you're having a dialogue with people about smoking cessation, and now we're looking not at the assessment stage, but you're beginning to develop a treatment plan. So if your assessment stage is just maybe 1 or 2 sessions, then you're looking at your second, third, fourth session to begin to better understand someone's smoking behavior. The more that you understand someone's smoking behavior, the easier time you'll have in developing behavioral approaches to help people stop smoking. At this stage, I kind of step away from psychiatric jargon and look more at normalizing cigarette use in the context of a stress coping mechanism. And so what I will do is spend time speaking about stress. Most people can identify having stress in their lives, and often stress is a more effective way of speaking about psychiatric symptoms than the specific symptoms in and of themselves. So stress in general is defined as a time when people feel or perceive that their coping strategies do not allow them to manage any kind of external stressor. That stressor does not necessarily need to be a negative stressor. So times of stress could be getting married, having a child, changing location, going to a new job. They can be positive stressors. But one's ability to cope with that change may be overwhelmed, and that could be a time when someone experiences stress. And stress has a cognitive component of feeling out of control, feeling overwhelmed, and also physical components that are the same as symptoms of anxiety, so increased heart rate, difficulty breathing, difficulty sleeping, restlessness, and changes in concentration. Once you've described that basic premise to the client, it may help them better understand times at which they experience stress, and also help them identify when they feel overwhelmed and what coping strategies they are using or not using at those periods of time. And in that time, you want to really emphasize a client's resilience. So what coping strategies do they have that are effective? That could include exercise, it could include socializing, it could include meditation, all kinds of things. And it's really important to have that discussion about positive coping mechanisms up front, because as we go along, you're going to be talking with the client about increasing their resilience to stress. And increasing resilience to stress includes the same behavioral modification as we would use to help deal with smoking cravings. And if you, again, pull that together for clients right at the forefront, that is often easier to continue to speak about smoking cessation and mental health in concurrent terms as you move along. So as we help clients, we look at finding strategies to minimize their stress as well as to build up their resilience. And this is also talked about in the stress diathesis model of mental illness, where you talk about someone's precipitating factors or perpetuating factors. So what were the stressful events that caused the illness? And what are the protective events that prevent the worsening of illness? So again, we're talking about what are the stressors and what resilience do you have inherently? What could you optimize? Okay. So all of us experience stress, and all of us experience being overwhelmed or feeling like their coping strategies are failing. That doesn't necessarily mean that you have a mental illness at that time. Mental illness is a more extreme, if you think of everything as being on a continuum, the development of a mental illness occurs at the more extreme end of that stress management failure, where there is a complete failure of stress resilience such that you're not able to function in your day-to-day life. You're not able to work, you're not able to socialize, you're not able to participate in recreational activities in a way that you once did. And usually there's a sustained period of lack of functioning. In general, we're looking at 2 weeks to a month for most defined psychiatric illnesses. Each individual has a specific predisposition to develop mental illness based on their level of stress resilience. And this stress resilience can be based on early life development of emotional regulation, and that can be based on genetics, early life experiences or trauma, learned coping mechanisms in your home. Also, people have some inherent learned resilience strategies based on their previous experience in therapy, again, resilience patterns taught by parents, so on and so forth. And so if we're all walking around with a specific vulnerability to be able to develop mental illness, then usually it's not until a specific stressor takes place that you have an acute episode of the mental illness. So one stressor may not cause a psychiatric illness, such as depression in some people. That same stressor may cause a psychiatric or trigger a psychiatric illness in another person based on their inherent predisposition. The neurotransmitters that are involved in this stress reaction are the hypothalamic pituitary axis. And in brief, these kind of regulate stress hormones such as cortisol, which elicit stress reactions. And this is also called the fight or flight mechanism. People who are chronically stressed will experience that chronic fight or flight reaction, high blood pressure, increased heart rate, problems with concentration, restlessness, jitteriness, and all of those are manifestations of anxiety and depression. When you're in this chronic stress state, it is hypothesized that you get structural changes in the brain, including decreased hippocampal volumes. In anxiety, we see decreased amygdala volumes and changes in the prefrontal cortex and anterior cingulate gyrus. What this means is chronic stress can lead to structural changes that seem to be correlated with the development and maintenance of mental illness. So looking at stress management is not a minor thing. It's a very important thing, and that can start at any level of intervention, whether someone has a predisposition to psychiatric illness, whether they don't. And when someone approaches you to begin smoking cessation, that's a particularly wonderful time to start to speak about stress management and increasing someone's resilience. All right, so if we look at the potential development of a psychiatric illness, one experiences an external stressor of some sort, either positive or negative. Then there is the perception of that stress. So not only are the stressors different, but the way we perceive the stress is different depending, again, on that vulnerability that I talked about before. One person may have a self-perception that they can cope with a large amount of stress, and so for that reason they may not feel overwhelmed and develop those kind of changes in the hypothalamic pituitary axis. Another person with what might seem to others as very minor stressors may feel easily overwhelmed and trigger that stress response. Naturally, when we do feel overwhelmed, we try to implement the coping strategies that we know. And some of those are adaptive or maladaptive. In general, we would try to put smoking into the maladaptive area of coping, or any substance use into the maladaptive area. Although when you're dialoguing with clients, it's very important to emphasize that you understand how smoking use or how smoking or substance use came to be, that it was a coping strategy, and that there may be positive aspects to the substance use, but then also try to underlie how that substance use is negative as well. And that piece, that validating piece, can often open up the dialogue and build your therapeutic alliance. Once someone tries to implement coping strategies, then you naturally have a number of behavioral changes that occur with the coping strategies. And these behavioral changes in and of themselves produce neurophysiological changes, which will dictate the development of mental illness. We've spoken about this already, that mental illness is one end of the continuum of this experience, and it really represents a complete inability of an individual to cope or tolerate stress that results in the biochemical changes that we see with depression, anxiety, or any other mental illness. It's really important to look at early interventions, and so many people will feel the minute they feel overwhelmed or depressed that they need to see a psychiatrist, they need to start on medications, they need therapy right away. That may or may not be true. You don't necessarily need psychiatric expertise in the beginning of an illness. You can start to do that counseling around stress management, about building resilience, around coping strategies. Lifestyle measures go a very long way in treating mental illness. And so those should always be your first step before looking to medications. Medications are necessary in some cases, and that you may want to involve a psychiatrist at the point where people are really impaired in their functioning. Certainly if someone is suicidal or experiencing symptoms of psychosis, you still communicate lifestyle strategies, but you would want medical intervention more urgently at that point in time. All right, so what I've done in this slide is to try and overlay maybe some of the interventions that could happen at each stage of the development of mental illness that we talked about before. So you have the occurrence of an external stressor. And right off the bat, you could start to do some problem solving around how to mitigate that external stressor. So in cases where we have clients admitted, these external stressors might be a collapse in their financial stability, a collapse in their housing, some other change in work or workplace stressors. And so often what will happen is we have a social worker on our unit who will meet with the clients to discuss ways of mitigating those external stressors, whether it be speaking with the workplace about temporary leaves of absence, or making adjustments in the workplace, finding financial support, or looking at housing supports. Next, you want to have an understanding of how somebody perceives the stress that they're experiencing. What is the meaning of that stress? Usually there is some catastrophic thinking associated with the stressor that's taken place, right? Like somehow people are going to be broke or homeless, and that may be the case or it may not be the case. And so it's really looking at people's perceptions. Are there cognitive errors that are occurring that you could help to mitigate with the client? Once you understand how someone perceives stress, it's easier to work with them at their level and to begin to understand the meaning of that stress in their lives. Then you can begin to talk about coping strategies, and it's really important to have a historical basis in coping strategies. What's been effective in the past? What hasn't been effective in the past? You have to be careful not to come up with coping strategies for the client, but use more of a motivational interviewing model where the clients themselves come up with coping strategies that have worked for them in the past. Those coping strategies that are generated by the clients themselves are going to be more effective and more easily implemented by the clients. Once you start to get into severe behavioral changes, again, you might want to look at involving a medical person or looking at more specific psychological treatment if you suspect that a psychiatric illness has developed. Okay. Behavior modification is really important in psychiatric illness. Behavior modification is really important in smoking cessation, and they are often exactly the same. What needs to be emphasized to the client right off the bat is that those strategies to stop smoking will also help their mental health in general, and tie them together right in the beginning. Fundamental to any kind of lifestyle management is increasing somebody's physical activity. And what we see more and more is that there's studies that show that increasing physical activity, particularly for mild to moderate depression, in and of itself can be almost as effective as an antidepressant. In fact, sometimes when we prescribe physical activity, we will put on a prescription pad just to emphasize the importance of that treatment modality. Physical activity is also important for smoking cessation, as physical activity can increase levels of dopamine, which is the same neurotransmitter that is increased when you smoke a cigarette. So physical activity can almost end up being a nicotine replacement to a certain extent. Guidelines around physical activity will emphasize the frequency of activity rather than the intensity of activity. So you're looking at asking clients to participate in moderate activity, which is walking at a pace where you can maintain, or doing activity at a pace where you can maintain a conversation with another person. And frequency should be at least 4 to 5 times a week, a minimum of half an hour to 45 minutes. Walking is a great activity that people can do, and if you combine it with social activity, then it's even better and more powerful for the treatment of mental illness as well as for smoking cessation. Always try to set goals with the client that are achievable. So even if they don't reach that 5-day-a-week goal or aren't reaching the goal around moderate activity, if you begin getting people active at a place where they feel comfortable and gradually work up to those levels of physical activity, that early engagement is more important than the end outcome of the intensity or frequency. Speaking about alcohol and drug use, again, coping strategies around alcohol and drug use are the same as for smoking cessation, and you want to tie those together as soon as possible. Nutrition, we speak a lot about nutrition with regards to psychiatric illnesses because many of the medications that are used to treat psychiatric illnesses can cause weight gain and increase carbohydrate cravings. As well, when somebody stops smoking, they can also experience increased carbohydrate cravings, and that's thought to be because of the decreases in dopamine that occur. So it's very important to talk to clients about ways of managing their weight, as many people will not adhere with psychiatric medications because of their fear of weight gain. As well, some people will be prevented from engaging in smoking cessation because they're scared of gaining weight. And this is seen particularly with young women who are smoking. So you want to speak to people about eating frequent protein-based meals and avoiding carbohydrates. You're going to have more increased carbohydrate cravings. However, with small protein-based meals, some of those carbohydrate cravings can be averted. It's also very important to emphasize hydration, as dehydration is often occurs with people who smoke, and hydrating in and of itself can decrease carbohydrate cravings. Sleep. So sleep is a really important factor in mental health. Often people present with difficulties with sleep as an early sign of mental illness, and is often the most concerning and disturbing symptom that they experience. Smoking actually decreases the quality of sleep that one has, and so smoking right before bed or smoking in the middle of the night is really disruptive to sleep cycles. And that piece of education is very important to give to clients, because often people have the perception that smoking helps with sleep. So reviewing sleep hygiene strategies and including smoking cessation within your sleep hygiene strategies is very, very important. Often that can be a motivator for people to decrease their smoking, particularly at night or in the evenings. All right, so psychosocial interventions. I've spoken about the psychosocial interventions in loose terms, but in order to kind of put them into sequenced terms, you want to begin with education. So during your assessment or after you've done your initial intake, you want to begin immediately with increased psychoeducation, both about illness, smoking, and the overlap between the two. Cognitive behavioral therapy is a therapy that's talked about a lot in depression and anxiety, and really the initial stages of cognitive behavioral therapy can certainly be done by anybody. Really what you're looking at in the initial stages of cognitive behavioral therapy is to be able to make a correlation between people's thoughts and their behaviors. So when we're speaking about stress resilient or stress management, I talked about people's perceptions of illness, of stress, and that's a time where you're actually examining people's cognitions or cognitive beliefs. I mentioned cognitive distortions, the most common one being catastrophizing. That occurs in both depression and anxiety. So to be able to really examine how people perceive stress and to help them rebalance those thoughts or look at them more realistically. The other piece of cognitive behavioral therapy is looking at how people respond to those thoughts. And when we're looking at smoking cessation, what are the thoughts that are associated with wanting or craving a cigarette? Even bringing awareness to that link can help people breathe, take time, and delay having their cigarette in response, or at least encourage people to use an alternate behavior as opposed to smoking a cigarette. So that awareness and that education piece is really important, even if you don't have the expertise to deliver cognitive behavioral therapy. That first stage is key. Okay. There's lots of evidence to support mindfulness in anxiety management, in stress management. Mindfulness-based therapies are really used primarily in stress reduction, and those therapies are thought to prevent the development of psychiatric illness. The same strategies could be used for smoking cessation. And the mindfulness strategies include being mindful of your cognitions, recognizing physical sensations, being more aware of what's going on, and kind of detaching from that impulse to reach for a cigarette or use other maladaptive coping strategies. Again, I mean, describing mindfulness is beyond the scope of this talk today. However, there are many resources online that look at mindfulness and many groups and communities that run mindfulness-based groups. So social support for recovery, both in smoking cessation as well as in psychiatric illness, is really key. And developing social networks is very, very important. That's why I said earlier, if you can combine two strategies like physical activity and social engagement, then you have a really great strategy for combating both the development of psychiatric illness as well as helping with smoking cessation. Often what needs to be done with clients who are struggling with mental illness is to be able to set some strict goals around social engagement. With all psychiatric illness, social isolation unfortunately ends up being an outcome and worsens the prognosis for recovery. So really taking an inventory of changes in social activity and helping clients step-by-step re-engage in social activities should be key. If someone is very involved in substance use culture or smoking is a component of their social activity, then that becomes a very complicated situation. Recognizing that substance use is a component of social activity and recognizing the difficulties that will be involved in re-engaging with social activity in the context of substance use is important right from the beginning to begin a dialogue about social reconnectivity, and then to start to look at other engaging in social activities where one will not be triggered with regards to their substance use. In some cases where people are involved in very heavy substance use, there's a process of grieving that takes place because many people find it necessary to step away from acquaintances or friends that they had who are still very much engaged in that culture. Right. I'm going to do a quick piece on psychiatric medications and the interaction with smoking cessation. This is not complete. However, in general, smoking does affect one of the mechanisms in the liver that does metabolize psychiatric medications, and that's a cytochrome P451A2. In general, you do not need to worry about smoking or stopping smoking affecting levels of psychiatric medication. The only exception to this rule is a medication called clozapine, which is used for treatment-resistant schizophrenia. Smoking really does affect the metabolism of that particular medication, and that medication needs to be monitored very closely. So if you have a client who is on clozapine and wants to engage in smoking cessation, it is imperative that a psychiatrist be consulted first, or another medical person who will be able to monitor those clozapine levels appropriately. Generally, when smokers with concurrent psychiatric illnesses do stop smoking, there are effects on the psychiatric medications. And that has been shown in studies through plasma medication levels. However, there haven't been consistent data to show that that affects anybody clinically, that the medication levels do. What is seen, however, is sometimes when people go through nicotine withdrawal, those symptoms of nicotine withdrawal can mimic symptoms associated with psychiatric illness. This is most prominent in people who suffer from anxiety disorders, where nicotine withdrawal actually mimics panic disorders or feelings of generalized anxiety, at which point in time people will assume that it's a problem with medication failure, or maybe increase medications, possibly unnecessarily. It's important to look really at nicotine replacement as a strategy in these cases to be able to mitigate some of the physical symptoms that can be associated with withdrawal before looking at immediately increasing the antidepressant. The relationship between psychiatric illnesses and smoking is still unclear. We do know that suffering from depression or anxiety does increase your risk of struggling with nicotine dependence. And also, we know that clients who have depression or anxiety have higher rates of nicotine dependence. The exact mechanism of this is not known. We talked about genetic predisposition earlier. That is a possibility. It's also possible that people who struggle with depression or anxiety actually benefit from nicotine in the sense that it might increase their dopamine levels or change the processing of some of those neurotransmitters. So in essence, people may be self-medicating when using nicotine in the context of depression or anxiety. In that way, it is felt that people who struggle with depression or anxiety may have harder times with cessation, and therefore use of medications such as varenicline or bupropion may be indicated in these clients, as they generally experience higher levels of nicotine withdrawal symptoms and have an increased sensitivity to symptoms of anxiety. I talked about this already, that increases in anxiety can be seen at times of smoking cessation. People, again, with anxiety disorders have that increased sensitivity to any physical symptoms of anxiety, and that could include increased sensitivity to withdrawal. So you may want to look at nicotine replacement or other medications for smoking cessation in clients who struggle with these illnesses. The complicating factor with bipolar illness is that medications like bupropion need to be used very cautiously because they could trigger manic or hypomanic episodes. And so one may want to look more towards nicotine replacement at the beginning. There have been limited studies in clients with bipolar illness and using varenicline or bupropion. So there's no absolute contraindication at this point in time. In schizophrenia, there is no contraindication to using any of the medications for smoking cessation at this point in time. There has been controversy around the development of psychosis with varenicline, but most recent meta-analysis have disproven that there is an increased risk with the use of this medication. Nicotine replacement is effective for people with schizophrenia and should not be overlooked as well. So this slide speaks about encouraging support for use of medications, that there's no illness in which medications are contraindicated, but that the medications should be monitored very closely. In fact, use of medications in recent studies have been shown in these populations to be more effective than in the general population. So it's certainly something that shouldn't be neglected. And this slide just says that there is no evidence to discount the use of bupropion in clients who suffer from schizophrenia. The reason that these slides are included is there is controversy, or has traditionally been controversy, about using medications in clients who struggle with schizophrenia or bipolar illness. At this point in time, there is no thought that there is a contraindication. All right, and this speaks again about watching out for that possible medication interaction in this P450 system, as there are some medications in schizophrenia, particularly clozapine, that could be affected. Bupropion does increase dopamine and theoretically could increase the risk of psychosis in schizophrenia. However, clinically this is not often seen. You may want to be more diligent about monitoring, but again, and I said it multiple times now, there would be no reason if a client wanted to engage in medication therapy that you would deny them that privilege. You've probably heard this in other talks, or you will hear it coming up. The use of a combination of nicotine replacement as well as medications is generally thought to be more effective for clients who are struggling with smoking cessation, and in particular, this seems to be the most effective strategy for clients who struggle with concurrent psychiatric illness. People will often ask me what I use as a first-line agent. I still tend to use bupropion because it is also marketed as Wellbutrin, and Wellbutrin in itself is an antidepressant. I tend to work with clients who have treatment-resistant anxiety or depression, and so bupropion not only helps with smoking cessation, but also helps augment antidepressants, and that's why I tend to use it as a first line. However, it would be completely fine to use varenicline as well. There have been mixed, in the past, evidence about varenicline in the development of suicidality and psychosis. Most recent meta-analysis have disproven that there are increased rates of suicidality or psychosis with varenicline. However, it's still important to monitor that closely. All right, so there is a case here, a case study from Sarah, and about Sarah, who suffers from smoking cessation, who wants to combat smoking cessation and is experiencing increased stress. I've used this in my talks in live discussions as a case presentation to think through strategies in order to approach this. In this case in particular, in this talk, I'm going to skip over this and just leave a couple of minutes to look at some of the questions, because I know that we're running short on time. However, if you have the time at the end of this webinar, this is a real case, and it's a good opportunity to think through your approach for Sarah with regards to stress management and smoking cessation. Okay, so one of the questions they have is, would it be advisable for each person who has mental health or addiction who wants to quit smoking to speak to a doctor first? I mean, that's kind of a tough question. It really depends what their goals are and how severe their mental health issues are. I mean, I think it's always great if you have access to a physician, to be able to speak to a physician to discuss the option of using medication therapy in smoking cessation, and to be able to assess what medications a client is currently on with regards to their mental health, so you can make sure that both are addressed if necessary. So, but does that mean that you have to see a physician before beginning to address these issues? No, that a physician is not necessary to begin that smoking cessation process. I would begin with what we talked about in enhancing coping and looking at triggers, all the things that could begin before seeing the physician. Is there a difference in use or precautions using varenicline simply because of the high rates of suicide in older men? I'm not sure exactly what that question is asking. In any of the populations who struggle with depression, there's no indication at this point in time that you wouldn't be using varenicline based on the increased rates of suicide. I think that's what that question is getting at. I'm not sure.
Another question that was emailed in.
Okay. I guess this will be the last question. I don't need for time. Okay, so I have one more question here, and I guess we will be looking at addressing other questions maybe at a later date. I can address them by email.
So following the webinar, if you have additional questions for Dr. Aleem, please feel free to email them in to tanyaabate@cambridge.ca. So my email address is on the side there, and you should have received email communications from me previously. And then I will send them off to Dr. Aleem, and she'll have them answered, and I'll email them out to everyone.
So this is a question on how people set boundaries with complex clients and deal with clients who are dependent on the practitioner and have trouble letting go. And that's a really complicated. This is a really complicated question. The really important thing the thing that I find important is to always set the stage for clients right from the get-go, where you are a person who's helping them facilitate change, but that the change, whether it's change around their mental illness or change around smoking cessation, comes from the client themselves. So you are a resource to help clients establish their own health. If you step in with clients right from the beginning and problem solve for them or take ownership over their mental health and recovery, then you're setting the stage for that dependence right from the get-go. So being very cautious and mindful about that right from the beginning. And if you stick with a motivational kind of model, both for illness, psychiatric illness, recovery from psychiatric illness, as well as for smoking cessation, you're kind of setting up that boundary right from the beginning. As far as being dependent on a practitioner, being available to clients is important, but having limitations around your availability is equally as important. So to set some strict guidelines around how appointments are going to be taking place and how clients can access you between appointments. So for instance, if you have a client who's frequently calling, you might want to ask clients to relegate those questions or those needs to frequent face-to-face appointments and limit inter-appointment calls. You want to limit emergency appointments or emergency scheduled appointments to situations that are truly emergencies. So you want to set up that education with a client as to times where emergency visits are warranted or not warranted. And again, really try to help the client maintain some structure around appointments. If they are able, particularly people with anxiety, are going to want to seek reassurance frequently and may want more frequent appointments or want to set appointments in between scheduled appointments, really that's not helping clients with their anxiety because they're not learning to develop coping strategies on their own. And you want to say that part of this is a therapeutic process, that if you're the person providing reassurance all the time, then people aren't able to developing those coping strategies on their own. And you'd be surprised, clients often with some education are able to maintain those boundaries if they're set from the forefront. Okay, so I think we're going to end things there. Thank you very much. I'm going to hand it back to Tanya.
Okay, thank you everyone for joining us today, and thank you Dr. Aleem for presenting. And again, if anyone has any questions, please feel free to continue typing them in the chat box or email directly to tanya.abate@canh.ca, and I will have the questions answered by Dr. Aleem. Okay. And again, a link to the evaluation as well as the post-learning assessment 2 will be emailed to everyone tomorrow, and you'll have 1 week to complete those requirements. And our next Lunch and Learn webinar is Wednesday, September 24th, so quite a while away, but applications are currently open through our website. Thank you again, everyone, for joining us.